Okay, so we have Mr. Torres, who is a 31-year-old male. He's presenting to the ED with progressively worsening shortness of breath that started 2 months ago. He came in today because he became dizzy while he was playing basketball with his friends. And as a child, he was told he had a murmur, but it was never addressed any further than that. So this would go in what part of your SOAP note? Perfect. Subjective. So go ahead and type that up in your subjective bit. I'll give you a second to do that. When the first person is done putting the S part in your SOAP note, just send a little thumbs up or say done, so that way I can gauge and I don't move too quickly. Awesome. Thank you, Caitlin. We're gonna push forward. If anyone needs me to go back, just yell at me. Yep. Okay, questions to consider. Does anybody have any questions for Mr. Torres? You can pose them to me as if I am Mr. Torres in the chat, or you can unmute and ask them. This might include what causes shortness of breath. So he's not, so as the patient, I'm not sure what's causing my shortness of breath, but it's worse when I'm moving. So sometimes it's when, yeah, that's a great question. So it's worse when I'm moving around. Usually when I'm going up the stairs. In the past couple of months, it's been really hard for me, but I'm in today because I was playing basketball with my friends and I got really short of breath and a little bit lightheaded. So that's why I came in today. But when I sit down and rest, it goes away a little bit. Great question. When did the dizziness start? The dizziness started when I became really short of breath when I was playing basketball. Anything else in terms of medical history? Not that I know of. I just know that my doctor told me I had a murmur back when I was a kid. But other than that, I think I'm pretty healthy. How long has he been dizzy? Has it gotten any better since he stopped it? Yeah, so I've just been dizzy since I was playing basketball. The dizziness has gone away since, but it kind of worried me, so that's why I came into the emergency room. I'm not taking any medications. That's a great question. Because certain medications can definitely cause a low blood pressure and can cause symptoms of dizziness. So that's a great question. Anything else? You can ask maybe associated symptoms to kind of narrow your thought process. You may also want to ask, do you remember what they did for your murmur earlier? So they didn't do anything for my murmur. I was just doing one of my routine physical exams when I was a kid, and they listened to my heart and they said I had some type of murmur, but they didn't do anything for it at that time. Does anyone in my family have problems? Oh, hold on. Anyone in my family have problems with these symptoms or history of, yep, family history is a great question for something like this. Anytime a kid comes in, anytime you have like a murmur or something like that, when someone comes in as a kid, these things tend to be congenital. So asking about family history is a really great question. So I think my maternal uncle had some sort of heart condition. He had surgery and he died shortly after. But I don't know the details of it. I don't have any leg swelling. That's a great question. Brandon, why are you asking about leg swelling? Sign of heart failure. Yeah, that's a great question. So if I'm having cardiac type symptoms, the thing that we're going to look for on the legs is what we call pitting pedal edema. So that means when you press into the leg, you kind of leave a little dent. So that's a great question. And that just means that if the heart isn't pumping properly, blood backs up in the veins because it's not going into the heart. It's not circulating through the chambers. So that will cause pressure up in the jugular vein to become a little high, and that will also pool in the legs and cause swelling. So that's a great question to ask. But no, I don't have any leg swelling. Does he experience any pain with dizziness or shortness of breath? That's a great question, Madeline. So I do get a little bit of chest pain when I'm feeling short of breath, and especially when I became dizzy, I did feel kind of like a tightness in my chest. That's a great question. Can I point to where the pain is? Kendra, that's great, because a lot of times patients will say I have chest pain, and then they'll point like to their stomach, or their chest pain is like really shoulder pain or something. So asking them to try to pinpoint exactly where it is on them is super helpful. We have our own anatomic terms, and so that's what we would document in the objective part during our physical exam. But where they're saying the pain is, that's subjective. History of smoking, alcohol, or drug use. Excellent question. I do not drink alcohol, and I do smoke marijuana daily, though, but no cigarettes and no illicit drugs. Yes, and both of you got the pitting edema. Anything else you want to ask, or maybe tests you might want to order? Anything else about my history or characteristics? EKG. That's a great one. If you guys were here last week, we talked a bit about EKGs. We won't get too into it this time, but yeah, so anytime someone's coming in with like cardiac type symptoms, we definitely want to do an EKG. And what are we looking for on the EKG? There are so many correct answers here, but just quickly. Abnormalities. Yeah, that's good. Q wave is a good one. Neha, why do you say Q wave? To see if it was an MI. Yeah, so a Q wave, for those of you who don't know, is a little downward spike that we only see in patients who have had an MI in the past. So it's like an artifact that you'll see on the exam. So if he has had a heart attack in the past, we would see Q waves. That's a great one. Trish, you said CT scan. That's possible. What are you looking for on the CT scan? Structural things. That's true. So this is something that I actually was doing wrong in medical school a lot, is I would always like propose a bunch of tests to order just because I was like, more information is always better. But these things cost a lot of money, so it's important to consider what we're looking for specifically. Like for instance, we may be looking for, say, an aortic dissection, which we could see on a CT scan. So if the patient, and I know that a lot of you don't know these pathologies specifically, so that this is a completely fair answer right now, but just something to keep in mind is when you're ordering tests, these all cost money to the patient. So we should be ordering these scans and these tests with things in mind. So that's why I'm kind of asking, why are we ordering the EKG? Yes, you're going to do it because that's what happens in the emergency room, but hypothetically, we should be doing it with purpose and kind of having a couple hypothetical diagnoses in mind. So CT scan is great. Structural abnormalities, we may see structural abnormalities in the heart, but we could do a cardiac CT for that hypothetically, but those aren't really ordered a ton. And just over here, we're seeing, yep, we're looking for STEMI perhaps. If he's coming in with chest pain, this could be an atypical presentation. Vascular Doppler, Cassandra, why are we doing a vascular Doppler? To test overall circulations, patients with ED often get this Doppler at the vascular clinic I work at. Okay, cool. So I don't think we would necessarily do a vascular Doppler on this patient. I'm not sure completely of what the indications are, to be honest with you. Typically, I think when we're doing those, we're looking for, in my experience, we're looking for DVTs. So if a patient is having like a bunch of swelling in one of their extremities, or they might be having like a PE, pulmonary embolism, we may want to like do a vascular Doppler to see like how's the flow. There may be a specific indication that I don't know for that though. Just to catch up on the comments, how fast is the heart beating? Yep, we would see that on the EKG. We can definitely see arrhythmia, Kendra, on the EKG. That's a great one, especially since he had a murmur. Jugular distension, yep, so that's kind of in line with the pedal edema if we were to be seeing problems with the heart pumping. And Madeline has asked, what is an alternative if the patient cannot afford an EKG? I actually am not sure. I think we typically do the EKG on everyone who's coming in with chest pain. I think you have to. It's just part of when people come into the ED, you have to treat them, and this is part of the initial workup for that. So EKG is kind of a standard one, but once we have admitted the patient. My comment was more to once we've admitted the patient. So you've been stabilized, we've admitted you into the hospital floor, and now we're trying to figure out what's wrong with you now that you've been stabilized. And if we're doing a working diagnosis and we order like MRIs, CT, bladder scan, whatever, and we order 10 million tests and 10 million blood tests and titers, that's usually not the most cost-effective thing for the patient. But something like an EKG, which is where trying to diagnose and triage and make sure that they're not about to die, I think that we typically have to do that in the ED. But to be honest, I'm not 100% sure, but I think we have to. So any more questions or tests or labs we want to consider here, keeping in mind what he came in with, keeping in mind things that we might think are wrong with him? It's okay if not, we're going to keep talking through it. Troponin blood test, Caitlin, why do you say troponin blood test? MI, perfect. So we can have a non-ST elevation MI, in which case we're not going to see those characteristic changes on the EKG. But the difference between like a non-STEMI and just like normal, just like angina, just happening because the wall is becoming a little ischemic, is that we would see elevated troponins in a non-STEMI. So that's a great one to look for. Pulse ox is great to see if he's oxygenating well, especially since he was dizzy. If he's had an infection lately, why do you say that, Kendra? Pericarditis, that's great. Yep, so we would see that. We talked about that a little bit last week. So we can see characteristic changes on the EKG. Because he's had it for so long, you can have chronic pericarditis. Leaning forward helps the pain, that's true, because that means that the sac surrounding the heart is inflamed. And so when it beats, it kind of hits up against the pericardium. So if I'm leaning forward like this and I have pericarditis, that kind of swings the heart forward and it stops laying right on the inflamed pericardium, and that will relieve the chest pain. That's exactly right. An infection lately, that would make sense. So for the infection, we'd see more acute pericarditis. So the fact that he's had this for a few months makes it less likely, but certainly it's something to consider. Let's keep pushing forward. Make sure I didn't miss anything. We did that. Okay, so I think we got through a lot of these. So childhood murmur, in his medical history, he doesn't know anything more than that. He is fully vaccinated, which we're asking because since he had a murmur, there are some diseases that you can have as a child that can cause murmurs. We won't get into that though today. So he's not taking any medications. Family history, his mom's got high blood pressure, and I'm sorry, it was a paternal uncle who had a heart surgery and he died at the age of 50 from complications after the procedure, but we're not sure why he had the heart surgery. Social history, no alcohol, but he does smoke marijuana daily. So this all continues to go in the S part of the SOAP note. So someone let me know once you're done taking down all this information, and then we can keep moving forward. Awesome, thank you. Okay, physical exam. So this goes in what part of the SOAP note? Perfect. So he's sitting up, no acute distress. He's a little tachycardic, heart rate's 110, BP is 130/90, respiratory rate is 20, temp is 97.6, and his O2 sat is 98 on room air. So these are pretty normal vital signs. He's a little tachycardic, but he might just be stressed because he's in the ED. Respiratory rate's a little high, but that could also just be like stress. So on the cardiac exam, which we're prioritizing, is going to be normal rhythm, but he has a harsh hollow systolic murmur at the right upper sternal border, so right here, with radiation to the carotids, meaning if I were to put the stethoscope up here, I would hear the murmur up here as well. But the PMI, which is the point on the ribs right here, which is where the heart is closest to the chest wall, we can actually feel it. You might be able to feel it on your own chest. It should be like right in like the fifth intercostal space, right over here. It's non-displaced, which means the heart isn't big. Respiratory exam, clear lungs to auscultation bilaterally, no wheezes, rales, or rhonchi, and no pedal edema, as was asked before. We're going to talk a little bit about murmurs, so don't worry too much about that just yet. And systole versus diastole. So if you don't know what harsh hollow systolic means yet, we're going to get into it. Don't worry about that. But you'll learn that this particular phrasing of harsh hollow systolic with radiation to the carotids is very characteristic of what we're looking for here. So you'll keep that in mind. There's a bunch of keywords for heart murmurs. Let me know once you have this all written down and we'll keep moving. Awesome, thank you. We're gonna keep moving. So I just wanted to highlight this real quick since I did say harsh hollow systolic at the right upper sternal border. This is just a quick diagram of where the heart sits in the chest. The ribs are numbered. So we have a couple regions on the chest that we listen to characteristically for these murmurs to listen to each of the four valves. So you'll notice that they don't lie directly on top of the valves, which for some reason before I learned this, I thought you're just going to listen to where all the valves are. But because we're listening to flow of the blood, we're kind of hitting it like in a vector of the way that the blood is flowing. So think about if the blood is coming here from the left ventricle up to the aorta, it's trying to go this way. So we're going to hear it, the sound is going to go like straight this way. And these aren't perfect maps. So like if I had a really bad murmur in the aortic valve, I'm going to hear it here, but I might hear it like in this entire region. So it's not just going to be in this one spot. If it's really bad, you might hear it also like throughout the entire chest cavity. But the mnemonic that I learned to keep this in mind, starting at the top right and kind of moving in a Z pattern, it's all physicians take money. So I think that that's a nice mnemonic to remember, the aortic, pulmonic, tricuspid, and mitral valves, just going in a Z pattern from the top right. Any questions about this? So based on what Mr. Torres presented with, do we know which valve might be implicated in his condition? Aortic, right, exactly. And we know that just based on where it is, and also radiation to the carotids is characteristic of this particular type of valvulopathy. Good. So here are some labs for him. His troponins were normal. They could be a little high just because the heart is stressed, but they shouldn't be right now. His red blood cells are a little low. He's a tiny bit anemic, but he's white blood cells are normal. So I think someone mentioned recent infection. Blood cells are normal and otherwise unremarkable. And this is his chest X-ray, which is a completely normal chest X-ray. Don't worry if this just looks like really confusing. I have a lot of trouble with chest X-rays. So really what we're looking for here is, because he's coming into the cardiac issue, we might be looking to see if the heart is abnormally shaped or enlarged. We're looking, of course, to make sure his trachea is open and midline, that his lungs are relatively clear. And that all looks pretty much fine. He looks fine on this chest X-ray. And here is his EKG. For those of us who were not here last week, I'm not going to go completely into this EKG, but does anyone have any notes about it? We're not going to read this today, but does anyone have any notes about it just based on things that they know, things that might look a little abnormal? Anything? Q waves, I'm not really seeing much Q wave here. So we would be looking for a Q wave like in a place like this, right here. And it would be right here between the P of the atria and this QRS complex of the ventricles. And so we're not seeing too much of that, which means he likely didn't have an MI before, but we are definitely going to look for that. P wave is maybe an odd shape. Yeah, some of these P waves look a little funky. I will agree with you there. So he's a little wide. So this could be the P wave, for those of us who don't know, represents the atria, the conduction going through those two atria on top of the heart. So if the atria are large, it will take longer for them to conduct, and therefore the P wave can look bigger. Sometimes it can have two peaks depending on which atria is large. That's good. Other things that I'm just going to note here is he's inverted QRS. So that's just due to the placement of these leads. It's a good note. These are really long QRS complexes, which is definitely important to note. Again, because the EKG is a representation of the conduction of the heart. If it's like a huge peak like that, that might mean that one of the ventricles is like a little bit thicker, so it's taking longer to conduct through that tissue. So this could just mean that he's got a big chamber on one of the sides of his heart. We won't get into that too much though. So now we're going to build a differential. Does anybody have thoughts about the differential, things we might want to continue working up, things we might think are wrong with him? Aortic valve issue. Yeah, definitely. Just due to the fact that we had a murmur up in the aortic spot, APTM, we definitely think there's something wrong with his aortic valve, which could be causing his shortness of breath, his syncope, aortic valve stenosis. Perfect. So there's two different types of things broadly that can go wrong with valves. There's stenosis of the valve, which means it's typically that means it's not opening properly. And then there's regurgitant valves, which means that it's not closing properly, essentially. So this is likely aortic valve stenosis, just due to the place in the cardiac cycle that we heard the murmur. The fact that we said it was hollow systolic, we're going to talk about that in a second, means that it's probably stenosis, because we heard it when we should be pushing fluid through the valve, versus it would be a diastolic murmur if it were to be regurgitating back through the valve and it didn't close properly. We can talk about that in a second, which is how we know it's stenosis and not regurgitation. Anything else that we think could be issue with him? Not really, right? That's mostly it. Yeah, so I put these here. We considered an MI briefly when we looked at his troponins and his EKG, and they were fine. He could have angina, which he likely has as a symptom of his aortic stenosis. So this patient, due to his age, likely has aortic stenosis secondary to a bicuspid aortic valve, which is a congenital malformation. How many cusps are normally in the aortic valve? 3, perfect. So yeah, nice to say, said nice. So typically we have 3 cusps, but we're thinking that he probably has a bicuspid one because he's so young and he's having aortic stenosis-like symptoms. We're not really going to see that in a 31-year-old otherwise. So the way that we work that up is we're going to do an echocardiogram. We're going to consult with cardiac surgery. We're going to start him on anticoagulants, and we want to counsel him on smoking cessation. So remember that for the assessment and plan, we address more than just the medical condition. If they came in with like a substance abuse, or if he was obese, or if he like wasn't taking his medications properly, those are also things that would go in the assessment and plan, because those are things that are globally wrong with the patient. So in this patient, I think the main thing is going to be counseling him about his marijuana usage. When you're done, let me know. And of course, if there's anything else you would like to add to the assessment and plan that I didn't put, you can add that. Alrighty, so let's just talk briefly about valves, because I know not everyone is going to be familiar with the anatomy. So we have 4 valves. We have back here is our aortic valve because it's going right up here to the aorta. Similarly, the pulmonic valve is right here up into the pulmonary artery. And we have down here mitral and tricuspid over here. So I guess I just wanted to talk about the direction of flow first. So we're coming in here through the lungs into the atria, down into this left ventricle. That's going to push up here through the aortic valve into the aorta. Similarly, we are getting fluid from the over here, which is why we see jugular venous distension. If the heart isn't pumping properly, we're going to back up here and we're going to back up down here, which can cause that pedal edema. So yeah, I guess I just wanted to paint that picture real quick before we keep going. So heart sounds, we should have 2 of them. We have S1 and S2. S1 represents the mitral and the tricuspid valves closing, and S2 is the aortic and the pulmonic valves closing. So between S1 and S2 is what we call systole, and between S2 and S1 is what we call diastole. So systole is basically the ventricles contracting. So between S1 and S2, we would want to push the blood up into the aorta to get it to the rest of the body. So in order to do that, we need these 2 valves here to be closed. So when this ventricle at the bottom contracts, we only push up through the pulmonic and the aortic valves, which are open during systole. So because he had a hollow systolic murmur, when the ventricles contract, we're pushing up through the pulmonic and the aortic valves, which are open. And we're going to hear that pushing through the valve because it's kind of like blood is rushing through and it's turbulent flow. And so we're hearing it through that stenosis of the valve. Similarly, in contrast, during diastole, we see the S2 sound. The aortic and the pulmonic valve should close. So that's S2. And then the heart, the ventricles, which have contracted and pushed through those 2 valves, relaxes. And so that allows blood to flow through these 2 open mitral and tricuspid valves. When it relaxes, it just kind of pulls in from the atria. And so that's going to be diastole. So that's when the heart is largest. That's when it is the volume within the ventricles is the most. And so that's diastole relaxation. Does that make sense to everybody? Anybody? Questions, clarifications? So here's a hypothetical question. Awesome, thank you, Neha. Hypothetical question for you. If we had aortic regurgitation, that would happen during which phase of the cardiac cycle, systole or diastole? Diastole, perfect. Yep, because we're relaxing. Good. Because hypothetically, we're pushing so much blood up through the aorta when the ventricles have contracted during systole that if that valve doesn't close properly, all of that high pressure blood in the aorta, some of it will pool backwards through the incompletely closed aortic valve if we have a regurgitant murmur. What about, here's a harder question. If we had mitral stenosis, would that be a systolic or a diastolic murmur? Mitral stenosis. Okay, so this is definitely a trickier question. So mitral stenosis, we're actually going to hear during diastole, not systole. And that's because when we have stenosis, imagine the stenotic murmur is going to happen when we're flowing through the valve. Regurgitation is flowing backward through the valve. So in a systolic murmur for the mitral, that would be if I'm contracting the ventricle during systole, and this valve here is not closed completely, that's actually going to regurgitate back through the mitral valve. And that would be the systolic murmur of mitral regurgitation versus during diastole, which is when we should be seeing blood flowing from the atria to the ventricle. That would actually be a diastolic murmur of mitral stenosis. So I want you to try to separate It's not like stenosis is always systolic, which would make things a lot easier. But think about which way that the blood is meant to be flowing. And if it's stenosis, it's abnormal flow through the valve. Regurgitation is abnormal backflow through the valve. I know it's kind of tricky, and it takes some time to get used to, which is why I asked that hard question. Sorry to trick you. So now we're going to talk about valvular aortic stenosis. So I have this little mnemonic over here. Major symptoms are going to be syncope, which is passing out, angina, which is chest pain, and dyspnea, which is shortness of breath. So the three main causes of this disease are going to be aortic valve sclerosis. So this is going to be calcification of the aortic valve. We sometimes call this senile calcification of the valve because if you're old, you develop more buildup in the arteries, similar to how you get an MI. You see atherosclerosis in the arteries. Similarly, we can get atherosclerosis around these valves. So a lot of times patients who are like elderly in their 70s, 80s, 90s, they'll have a little bit of a systolic murmur at the aorta just from age. Now, if we have a younger patient who's looking like they have aortic stenosis, that's concerning. So then that's when these younger two, the latter two are going to become more likely in our differential. So bicuspid is going to be in utero, two of the valves, two of the leaflets fused together. And I have a picture of it in another slide. And this is the most common valve formation, typo, sorry. And it's mostly in males, which is why this is Mr. Torres. And then rheumatic fever is a disease caused by strep. And so if he had any childhood illnesses, which I think someone had asked if he had a recent illness, which was a good question for pericarditis, but we also would want to ask maybe, did you have strep as a kid? And if he did, then it's possible that that affected the valves, that can cause some vegetation on the valves, and that can present with late aortic stenosis. So this is very common in third world countries. When you see a question stem, if they're in a first world country like the US, it's probably an old person with calcification. And if it's someone who's from one of the third world countries, you want to consider rheumatic fever as what could be causing the stenosis. So here's some pictures of bicuspid valves. So here you can see where we have these three leaflets, and there's a couple different ways they can fuse in bad ways. So this particular one is down here. We should be seeing what we call the Mercedes-Benz sign, because we should be seeing 1, 2, 3 little lines like that, like that. But we're not seeing that here. We're seeing abnormal fusion of some of these commissures. So now I want to talk about prosthetic valve replacement because there is no treatment for aortic stenosis. There's no medication that we can give that can cause the calcification to go away or that can cause the valve to like open up. We must replace the valve if you have severe aortic stenosis. And here are the indications, or some of the indications. This is not definitive. Would you be able to tell if you got rheumatic fever during or soon after having strep throat, or would it be something you would only find out later in life? That's a good question. You're typically not, so I mean, you'll have rheumatic fever, which you get, there's a specific criteria, it's called the Jones criteria, that can help to diagnose rheumatic fever. Not everyone who has strep gets rheumatic fever, but it's caused by a similar bacteria. If you're going to be developing valvulopathy from the rheumatic fever, that's not usually something that happens immediately after. We can do blood tests to see if you had strep in the past. If someone is presenting with vegetation on the heart, we'd see that on the echo. So in that case, we can go back and run a blood test and see if it's rheumatic fever. But if it's severe enough, then we're just going to go in and replace the valve. That's a good question. So yeah, what is the hollow part of hollow? Oh, good question. Thank you for clarifying. It just means that it's happening for the entire course of systole. So we might have like just a systolic murmur, just tells it happens somewhere during systole. We can have a late systolic murmur, which means it happens closer to S2. We can have an early systolic murmur, which means it's just right after S1. Or we can have a hollow systolic murmur, which means it's really big and it happens throughout the entire course of systole. That's a great question. So again, there is no treatment for aortic stenosis. We must replace the valve if it's severe. And we really have two flavors of valve that we can replace with. We have mechanical and we have biologic, which is typically porcine or bovine. So the differences are listed here. The pros of a mechanical valve are going to be it lasts a much longer time. So typically if we have a younger patient like Mr. Torres, we're probably going to consider a mechanical prosthetic valve for him because this will last longer and we won't need to repeat the surgery. However, with a mechanical valve, they need to be on anticoagulation for the rest of their life. Does anyone know why we would have to be on anticoagulation? Yeah, exactly. So having any sort of material in the body that's not biologic will cause a little bit of like reactive inflammation in the area, and that can cause blood clots to form in and around. Also, we get what's called, Parab is bringing up shearing. So anytime you have hard things sticking out of places where they don't belong, like on a valve or like a fake valve, we can get those little red blood cells that flow through can shear and they'll split open, which could be part of why he's a little anemic. If it's shearing on his like calcified valve, that can cause a tiny bit of shearing. But definitely with a mechanical valve, we can see shearing. So we would see that on, if we did a peripheral blood smear, we might see abnormally shaped red blood cells. We may see anemia. So that's a great point to make as well. However, now in other types of patients, we may consider, especially if they're older, we might give them a biologic valve. They don't need to be on anticoagulation for as long. It's not a long-term anticoagulation. It's just right after surgery because of all the stuff going on during surgery, you're more likely to form clots kind of as a result of the procedure and also just as a result of some of the drugs running through your system during the procedure. So you need to be on anticoagulation afterwards, but you don't have to be on it forever. So we had a patient during one of my clinical rotations who had bicuspid valve and he needed replacement, but he admitted to, this was his second valve replacement. He did not take his anticoagulation medication regularly. He often forgot. So he should have, because of his age, he was a young man. He probably should have been a candidate for mechanical. However, due to him admittedly not taking his anticoagulation regularly, he was at risk for clot, stroke, MI. So we actually ended up giving him a porcine valve instead, because that way he wouldn't need to be on anticoagulation for as long. So it is on a case-by-case basis. These are just general things. Can valves be treated with medication? That's a good question. So no, not really. There is no medication that can fix a valve that's not functioning properly, but we can give drugs to change the way like stents, like with anticoags. We're not gonna stent a valve open, and I'm actually not sure if we coat valves in the same way that we coat stents. So he's talking about how sometimes when you stent someone, like if they come in with a heart attack, we can put a stent in one of the coronary arteries to keep it open. Sometimes those are coated in anticoagulants, and that changes the anticoagulation regimen that we give them afterwards. Yeah, no problem. So we're not going to stent a valve. We're going to replace the valve specifically, but that's a really good question. I forgot what I was saying. Oh, we can give medications to treat symptomatically the patient. So like for instance, if his aortic stenosis was not super severe, he may not be a candidate for surgery yet, but if he's having chest pain when he's exerting himself, we might be able to give him like a beta blocker or something that will help his heart contract a little bit less vigorously. So we're pushing less blood vigorously through the valve and possibly slowing down the progression of the disease and treating him symptomatically. So we can do that, but nothing is going to fix the valve, unfortunately. We have to just replace it. So there's a couple different surgical approaches to this, and I think I have a picture of it coming up, but we can do it transcatheter, we can do percutaneous valvuloplasty. Alrighty, so here are some pictures of different ways that we can approach this. We can go through the femoral, we can go this way through the apex of the heart, which is over here. This is the base of the heart up here. We can go transaortic, we can come in through the neck. We can do fully open heart, or we can do minimally invasive. So we don't see open heart as much anymore. A lot of them we're veering more towards this. And there are specific indications for when you pick each of these, and we won't go into it because honestly, I'm not an expert on this. But here's a transaortic one over here, and we're replacing the valve over here. So that's what it looks like. And here are just some of the approaches in general. But there are indications for each of these, and there's no way to make a general statement about which patient gets what. Here's some pictures that I think are pretty. So here's replacement of a valve. This is a model to show what the valve looks like. Here they are prepping to put the valve in. Here they are, I think they're dissecting some stuff away. And here you can see they have fully replaced this with a biologic valve. Really pretty, that's neatly done. So this is a balloon valvuloplasty over here, little balloon to inflate. Really pretty parts. So catch up on Mr. Torres. I guess I wanted to ask you guys first, what do you see in this chest x-ray? The stitch work is epic, that is correct. Metal valve, yeah. So this is actually not a picture from this, obviously none of these are pictures from a real patient because HIPAA, but this is actually two different valves. The aortic and the mitral valve are both replaced, and you can see that little metal ring here and here from these valves. Does anyone know what these are? To close the sternum, that's correct, yep. So this guy had an open heart procedure, and we can see that from the metal closing the sternum after it was sawed open. So that's cool. They like to ask you that at medical school to see if you can find fun stuff on the x-rays. But this is otherwise a normal chest x-ray. And then this is a picture of a mechanical valve. This is not for the aorta. So I think it's a mitral one. And that's all I have. So I know this one went a little quicker than last one. I know all of that stuff with the heart sounds is kind of confusing. So do you want me to go back and clarify anything? Questions, comments about heart sounds, murmurs, cardiac cycle and flow? Anything like that? I'm happy to stay for as long as you guys have questions. Oh, quickly before people start leaving, we have the 10-question quiz that Becca had sent earlier. And please do your best. I think you can take it multiple times. And I'm not sure if there's another session next week. What specifically causes the heart sounds? Does anyone want to answer that before I jump in? Closing of the valves, that's correct. And do we remember what correlated with which heart sound? Say S1, what did that correlate with? Lub, yep. Tricuspid and mitral is going to be lub, and dub is going to be, that's our S2, and that's going to be aortic and pulmonic. Perfect. Any other questions or clarifications? Can we run through the plan for the SOAP note again? Sure. So because this patient came in with a pretty straightforward diagnosis, our plan is really just to kind of, we wanted to make sure, first of all, that he had a bicuspid valve. Yes, I can. I will go back to that now. There you go. So the plan for him was really, first we wanted to make sure that he had a bicuspid valve. It sounded like he had aortic stenosis. He's really young, so we're going to do an echo. We're going to make sure that his, we're going to check the flow. We're going to check through the echo. There's a lot of very specific parameters I won't get into to determine the severity of aortic stenosis. And they do this for every type of valvulopathy. So we're going to see how severe it is with the echo. And from there, we can see if he's a candidate for surgery. So we're going to do the echo. We are going to do, that's part of the cardiac workup for him. We're going to consult with cardiac surgery, make sure that he is a candidate for it, consult with them, ask all the appropriate questions about what type of valve is most appropriate for him. We may be starting him prophylactically on medications. For instance, if we thought he had rheumatic fever, we can start him on antibiotics, but we're not going to do that for just any patient. He doesn't look like he has rheumatic fever at all. We can start him on anticoagulants. Perhaps, I don't know if we would do that prior to surgery, actually, because we don't want him to bleed out on the table. But, and I think I misspoke in the assessment and plan about that. It's fine. So mostly we're doing the echo, we're consulting with surgery, we're gonna make sure that his medications are appropriate, his labs are within normal limits. And then I also just wanted to do some social counseling with him about his smoking habits, just to make sure that he's not smoking other things, and that he's minding his lungs, because smoking will cause damage to the lungs, which affects the cardiac system, which he's having issues with. It can also accelerate atherosclerosis. And so we want to make sure that we're counseling him on that as well. And I think that's primarily the assessment and plan. And then we just kind of passed surgery. Are these mechanical valves magnetic? Can they still have MR scans? I don't know the answer to that. I'm sorry. I guess it would depend on the kind of metal, perhaps. Honestly, I don't know. I wish I knew the answer to that. But I can't imagine that we would throw him in the machine and his valve would come like flying out of his chest like a horror movie. That sounds horrific. I've heard those stories about people who had like bobby pins in their hair, or they had like some type of wig on and they didn't tell people, and then it like flew out during the scan like a bullet. You mentioned that patients who had mild anemia. Why do we see anemia here? So this is likely due to shearing, as was mentioned with the valve. It's possible that because his valve is kind of calcified and abnormally shaped and a little rigid, that when the red blood cells are flowing through during systole, we might be seeing some of those blood cells shear and break apart. So when we do the lab testing, we're seeing less red blood cells overall. And that might be causing the mild anemia that we see here. More so, we're going to look for that after we replace the valve. It's likely that he'll have some shearing from the mechanical valve that we place in him. And target sign 2. So we see, okay, so target sign is something that we see on peripheral blood smear. We see that in, we can see that in valvular abnormalities. We see that in thalassemias. We see that in liver disease. I don't know if we're necessarily going to see it in this patient. I think we're going to see what's called schistocytes, more likely. I'm probably not saying that right, but it's like SCHISTOCYTES. And we typically see those from mechanical shearing. But target sign is a good one. I didn't learn about that until med school. But that's a very specific thing that we'd see on peripheral blood smear. We don't really have indication on this patient to run a blood smear necessarily, because we don't really feel like there's anything wrong with his blood. So it's just kind of like a more of an educational point that like we would probably see sheared blood cells on smear, but it's not going to be part of the workup. As I was saying earlier, that would be what I would probably consider to be an unnecessary test for him, unless you have a hematologist on your team who really likes blood smears, which happens, I guess. Any other questions? Oh, I can make a note here about the dizziness. So a lot of times we see in patients with aortic stenosis, they'll come in because they passed out. So part of the syncope workup, if someone like passes out, especially if they're older, is going to be to do an echo on them, because we want to see if they have aortic stenosis. Because if we're not getting enough blood through the valve out into the aorta, because the valve is so stenotic, we're not going to get enough blood to the brain, and that can cause you to pass out or become very dizzy. So not only in patients who look cardiac, who come in with like chest pain, shortness of breath, but even just anybody who passes out, a lot of times we're going to start with a cardiac workup as one of the things that could have caused you to pass out. Even in a younger patient, maybe they have bicuspid valve. So there's like a bug in my apartment. But that's part of the workup for that as well. So the fact that he was dizzy, when you ever see a dizzy patient, you want to ask them if they passed out. especially this guy, because that would increase the severity in our mind of his stenosis.